Becky, ready?
Yeah, ready.
Good afternoon and welcome to Cardiovascular Medicine Grand Rounds. It is my great pleasure to welcome and introduce our distinguished guest speaker today, Dr. Rebecca Hahn from Columbia University, New York. Dr. Hahn is a world-renowned expert in echocardiography and valvular heart disease. She is a pioneer in the field of interventional echocardiography and has helped shape its role in guiding structural heart interventions for valvular heart disease. Dr. Hahn received her medical degree from Washington University in St. Louis and completed her subsequent training in New York. She joined the faculty at Cornell and then became Echo Lab Director at North Shore University Hospital before being recruited to Columbia University, where in 2009 she became the first Director of Interventional Echocardiography for the Structural Heart and Valve Center. She's currently Professor of Medicine at Columbia and Chief Scientific Officer of the Echo Core Lab at the Cardiovascular Research Foundation. Dr. Hahn is a true leader in the field, publishing over 400 articles and serving on multiple ASC guideline writing committees. She was also the national PI for the SCOUT trial evaluating the tri-align annuloplasty device, and she's the national co-PI of the TRISCEND 2 pivotal trial evaluating a transcatheter tricuspid valve replacement device. In addition to all of these accomplishments, Becky is a thoughtful, dedicated, and valued colleague, and I know firsthand how much other Echo colleagues from around the country and the world value her insight and advice. We're really looking forward to her talk today titled Novel Concepts of Tricuspid Regurgitation, Anatomy, Pathophysiology, and Management. Becky, welcome, and the floor is yours.
Thank you so much for that generous introduction. I hope I can deliver on everything that has been promised. This is indeed a field that's growing and is rapidly progressed, and so I hopefully will be able to cover all of the learning objectives today, which are to examine the prior and current understanding of tricuspid valve anatomy and pathophysiology, and then review the novel classification and assessment of TR severity and RV function, and then review the role of surgery and transcatheter devices. So we know from the Framingham study that, as with all valvular heart disease, tricuspid regurgitation increases with age. But we also know that there's a 4-to-1 prevalence of females to males once they reach their 70s and 80s. This has been confirmed by other studies, and the overall prevalence of moderate TR in the early studies was felt to be under 1%. But as we begin to understand the disease better and diagnose it more appropriately, we see that the overall prevalence has increased, and indeed, in the most recent look at echocardiographic databases, we see that the prevalence may be indeed higher than the other valvular heart disease, which has not been studied, not been shown before. And so in this look at the prevalence of valvular heart disease, you see tricuspid regurgitation is at the top. And by the time you're reaching your 70s, 7% of patients will indeed have significant tricuspid regurgitation. When you look at outcomes of the various heart diseases, you can see that the hazard ratio for all-cause and cardiovascular mortality is actually the highest for tricuspid regurgitation. So this is a disease that indeed deserves our attention. But there are a lot of early misconceptions about tricuspid regurgitation, and some of them stem from this early study in mainly rheumatic heart disease patients who had mitral stenosis or mitral regurgitation, that the tricuspid regurgitation was just an innocent bystander, and that if you repaired the mitral valve or replaced the mitral valve, that the pulmonary hypertension would improve and then the tricuspid regurgitation would go away. And so in this study, they suggested that you didn't have to treat tricuspid regurgitation concomitant with mitral disease, that indeed it was an innocent bystander. And so that's our first misconception, which was that tricuspid regurgitation would resolve following left valve surgery. But indeed, the tricuspid valve is designed to be incompetent, and this was back from the 1800s. They knew that there was something different about that valve, and we'll show you some of the pathophysiology. So it does seem as though when you look at patients without a tricuspid valve repair at the time of mitral valve repair, that moderate and severe tricuspid regurgitation progresses. But even in those patients that have had a repair, we know now that there is a progression rate even in those patients. And we know also that it continues to be a progressive disease based on a number of different risk factors. This is a nice review looking at those risk factors for significant tricuspid regurgitation after a repair, and you can see that there are morphologic predictors such as annular size and leaflet tethering, as well as LV and RV function, and then clinical predictors like female gender, chronic atrial fibrillation, and then presence of left ventricular disease, as well as chronic pulmonary disease. And then, of course, surgical predictors and the type of repair that you might do. The CT Surgery Network trial looked at the patients and tried to determine what the predictors were for greater than or equal to moderate tricuspid regurgitation 2 years after mitral valve repair. And it turns out it's mitral regurgitation recurrence, which makes sense, but also the presence of a permanent pacemaker or defibrillator. And this really should be our first clue that these patients with defibrillators or pacemakers across the tricuspid valve are actually a different population of patient. Indeed, those patients had adverse outcomes associated with TR progression and greater than or equal to moderate TR at 2 years. Other studies have looked at the progression and predictors of progression and the outcomes associated with that progression rate. And this study comes out of the Leiden group, which has a very large patient population of untreated tricuspid regurgitation. And you can see here that any amount, so more than none, tricuspid regurgitation predicts it's going to get worse. And so tricuspid regurgitation begets more tricuspid regurgitation. And indeed, this study showed that any left valve surgery without a concomitant tricuspid repair or a replacement was also a predictor of a faster rate of development of TR. And indeed, that fast rate, so the time FASE was considered less than or equal to 1.2 years, a progression of 1 grade, then you can see that it predicts outcomes, and this is all-cause mortality. When you look at large populations, and this was a study that attempted to identify in 1,500 patients, the population attributable fractions, and they first looked at the typical risk factors for TR progression: age, female sex, pulmonary hypertension, atrial fibrillation, ICDs or pacemakers, left atrial enlargement, heart failure, and valvular disease, and discovered that the largest contributors to the presence of significant TR were indeed, and progression of TR, were PA pressures of as low as 36 millimeters of mercury, left atrial enlargement, which for me is a surrogate for high left atrial pressures or LVADPs, and then age greater than 60 and atrial fibrillation. And so those are the 4 factors that in natural history studies suggest that those patients are progressors. Now, we know that it's not just about the clinical factors, but it's also about echocardiographic factors. And so this is a study that looked again at progression of tricuspid regurgitation, and it was indeed predicted by the grade of TR at onset, at the beginning of evaluation, RV dysfunction, pulmonary pressures, and then, of course, the rate of progression. So TR progression indeed predicts outcomes. Now, this is a new study that looked at 1,800 patients and found that in patients who came with a diagnosis on echo of at least moderate tricuspid regurgitation, that 38% of them regressed and that 18% progressed. And so if you look at the multivariable analysis for the predictors of cardiovascular mortality in those patients with moderate or greater tricuspid regurgitation, if you had regression or no change, then your outcomes were not determined by that severity of tricuspid regurgitation. But if you had progression, particularly progression to massive or torrential disease, and this was over a follow-up period, a median of 2.3 years, then you had a significant adverse outcome. And so again, it is the progression to significant disease, but also massive and torrential. So those are new grades of severity that we'll talk about in just a minute. So when you look at the old, just historical studies, you can see that there's always been a graded response of tricuspid regurgitation to outcomes. And so whether you have mild versus moderate or severe, you would have worse outcomes. And this was true in natural history studies of just tricuspid regurgitation, but in the presence of heart failure, mitral regurgitation, aortic stenosis, or aortic regurgitation. And many investigators felt that the TR was just a marker for advanced disease but was secondary and not really a primary determinant of outcomes. And so it was an innocent bystander to the primary disease. And again, we know that functional disease is the majority of patients that come to us. But when you look at this meta-analysis looking at 70 studies, you can see that the adjustment for various comorbidities like RV dysfunction, atrial fibrillation, mitral regurgitation, left ventricular ejection fraction, and pulmonary pressures continued to show that tricuspid regurgitation was an independent predictor of outcomes, and therefore, really TR is not an innocent bystander. In fact, when you look at long-term outcomes, and this is probably the longest-term outcomes we have from the National Echocardiography Database of Australia, you can see that at the incident diagnosis of mild tricuspid regurgitation, over a follow-up period of about 20 years, you had a 30% increased risk of all-cause mortality. And so even mild, which obviously because it's a marker of progression, is a predictor of adverse outcomes. So when we want to understand the pathophysiology of tricuspid regurgitation, we really have to know the anatomy. So we'll cover the anatomy in the next few slides. We know that the annulus is a D shape. It is bound by the septum, which forms the flat part of the annulus. And then there's a curved region anterior and posterior to the valve. And there are multiple crisscrossing muscle bands directly attaching the base of the leaflet to the RV. And we can see these pretty clearly on echocardiography, which then determines that what's happening to the RV may actually determine what's happening to the valve. And then we know also that the annulus itself is virtual. When you run your finger across from the right atrium to the right ventricle, you can't feel any fibrous band that might determine the position of the annulus. And I'll show you the histology of the annulus in a minute. When you look at physiologically, what the annulus does is because it is tethered to the septum and it has highly mobile and attached to the RV free wall, the shortening and longitudinal shortening of the RV free wall, which is the primary motion and determinant of cardiac output in a normal patient, naturally will move the annulus toward the apex. And therefore, when the valve opens in diastole, there's a natural transfer of the blood toward the RV. And so this hinge-like motion is what allows the RV to be extraordinarily efficient, or at least the right heart to be efficient in the transfer of the blood from the right atrium to the right ventricle. Now, this is the histology that I was telling you about, where you have right atrial myocardium going directly to the right ventricular myocardium. And there's a little space in between where there could be fibrous tissue. And the greatest distance between the atrial muscle head and the ventricular muscle head occurs along that anterior superior side. And that's typically the side and along the lateral portion of the annulus that we see the greatest amount of annular dilatation. We know also that the dynamics that I just showed you is extraordinarily important. And atrial fibrillation reduces that dynamism, which allows the efficient transfer of the blood. But it occurs also in those patients with tricuspid regurgitation and sinus rhythm. So although it occurs more often in atrial fibrillation and possibly the atrial fibrillation itself is the cause of the reduced efficiency of the blood transfer, we know that it also occurs in the setting of sinus rhythm. Now, why is the blood so efficiently transferred? Not only because of the motion, that hinge-like motion of the annulus, but it's because of the relative orientation of the SVC and the IVC. So that in a normal patient, this beautiful helix is formed, which obviously creates energy and movement of the blood. And therefore, if the IVC-SVC relationship is normal, you will see this helical motion that allows the blood to be driven forward across the tricuspid tricuspid valve. That relationship of the IVC SVC changes with age, and so as you become older and you change the relative positions, you lose this helical motion, and there are more vortex and turbulent flow in the right atrium with less efficient blood transfer. We know that the annulus is not just that single dimension in an apical four-chamber view, which our guidelines like to use, but it's three-dimensional. And we talked about how it will dilate out the anterior-posterior side, but maybe not necessarily entirely out the lateral or the anterior lateral side, but not necessarily the posterior lateral side. And so when we're measuring the annulus from an apical four-chamber view, it all depends on the angulation of that image when we're measuring the tricuspid annular dimension. And so I think it's probably not a great idea that we use a single dimension of annulus to, in our guidelines, determine when to intervene on our patients. We know it's a three-dimensional structure. We know that it has three-dimensional changes in perimeter area and diameter. We also know that it's different in men and women, and that women, when you index for body size, may indeed have larger diastolic and systolic dimensions, perimeters in particular, when compared to males. Now, why is it that females obviously have larger annuli when indexed to body size? And we know that it's increased in 4-to-1 prevalence by the time you reach your 7th and 8th decades. And so when you look at the histology of males versus females, you can see that males have more myocardial bundles and indeed have more dense elastic fibers. And these are continuous elastic fibers in the annulus, whereas females do not. They tend to be discontinuous. Now, females may have more collagen fibers, which may help to retain the shape of the annulus, but it is really this interrupted and low density of elastic fibers that may predispose to stretching and extension, particularly in females with high parity. And so we do believe there may be a relationship, as there is with atrial fibrillation, to parity, and one of my fellows is now evaluating that through the UK Biobank. Now, when we look at tricuspid leaflet morphology, we discovered early on that it was highly variable. And so using three-dimensional en face views, we could see 3, 4, 5 leaflets. And so because of that, and because the TEER devices were being investigated, we decided with the 3 other institutions to look at patients and to try to determine the relative prevalence of these complex leaflet morphologies. And by echocardiography, we aren't necessarily able to determine a cleft or a fold from a separate leaflet. But really, for the TEER devices, it's less important that we do so. Those, whether they're clefts or folds or true leaflets and commissures, really all still make it more difficult to get our TEER devices in, and typically also predict a greater number of chordal attachments. And so what we found was only 54% of patients have 3 leaflets, and the rest have a variety of different conformations. But the most common, and possibly in the patients coming for transcatheter devices even greater than 3 leaflets, is the 4 leaflet conformation with 2 posterior leaflets. So very, very common to have the 3B conformation, which is the 2 posterior leaflets. And I've had a lot of discussion with a variety of different people about the true existence of these leaflets. And then when I went on to the University of Minnesota Visible Heart Lab, they've got all these examples sitting for anyone to download. And so I've downloaded the movies showing again the type 1, which is 3 leaflets, a type 2. So these are maybe small little clefts, but in fact, it's primarily just 2 leaflets, as you can see from the ventricular side. And then this is an example of a 3A with a little fold or a cleft in the anterior leaflet, and then our classic 3B, which is 2 posterior leaflets. And the little blue dot is where the anterior papillary muscle is, which is how we identified anterior and posterior. And then these are the multi-scalloped different leaflet conformations that can be seen. I mean, this is an outrageous number of leaflets here, like 6. This has been confirmed by other pathologic studies, and we're conducting our own pathologic studies with the University of Padua, but again, showing that these leaflets are extraordinarily complex. Now, the tricuspid valve is also obviously attached to the right ventricle, and so when you look at the morphology of the papillary muscles, we learn that there's a large, consistent anterior papillary muscle feeding chordae to the anterior and the posterior leaflets. And this papillary muscle, which you can see from the ventricular side, this is the RV alpha tract, so this is anterior, this is septal, this is posterior, that this large anterior papillary muscle is indeed attached to the lateral wall of the RV. And the lateral wall of the RV tends to be very sensitive to pressure, and will dilate. If you think about McConnell sign, will dilate with increased in pulmonary artery pressure. And so when it dilates and pulls out the anterior papillary muscle, now the anterior and the posterior leaflets no longer will coapt with the septal leaflet. Now the septal leaflet is very unusual and not at all like any of the leaflets, the mitral valve leaflets. And so the septal leaflet has numerous direct septal contacts, chordal contacts to the septum. And so although posteriorly, we often see some posterior papillary muscles that attach to not only the posterior leaflet, but the posterior segment of the septal leaflet, we often anteriorly have many, many anterior chordae directly to the septum. And so it makes the septal leaflet very sensitive to any changes that are occurring on the left side of the heart, and hence the ventricular interdependence of this particular disease process. Now, the shape of the RV is just a beautiful thing. We've already talked about that hinge-like motion of the annulus, but it's this U shape of the inflow-outflow that also allows the efficient transfer of the blood from the inflow of the tricuspid valve out the outflow of the pulmonic. And the heavy trabeculation of the apex also ensures that not a whole lot of blood will get caught up in the apex. It's unnecessary. It wants to just move the blood from the tricuspid valve to the pulmonic valve, and that increases the efficiency. 4D MRI shows you that beautiful efficiency. These are normal on the far left and in A, and you can see that the beautiful U-shaped flow goes straight out. It barely touches the apex, but as you begin to see some LV abnormalities, so this is a patient with very mild left ventricular disease, you can now see vortex formation toward the apex. And if you have pulmonary hypertension, then the vortices within the RV and close to the valve are just outrageous. And so either pulmonary hypertension or any kind of left-sided disease will also significantly affect the function of the right heart, and therefore the tricuspid valve as well. Now, when we're talking about pathophysiology and TR quantitation, we now can understand how inaccurate we've been when assuming that the tricuspid regurgitant orifice area is a circle, right? So we know that when we pull out the lateral papillary muscle, that big anterior papillary muscle, we're going to pull away the anterior and the posterior leaflets, and we create this that's either star shaped, depending on the number of leaflets, or triangular shaped, but certainly atypical and non-circular shaped vena contracta. And so using a single dimension like 7 millimeters from an apical four-chamber view is just almost ridiculous in trying to describe the complex nature and the severity of tricuspid regurgitation. And so although we now use biplane and use a larger dimension of 9 to indicate severity of disease, we know that even that is going to be highly inaccurate. And in fact, when we advocate for the use of quantitation, our guidelines strongly recommend proximal ice velocity surface area. But the problem with that is that none of the assumptions of PISA will hold for tricuspid regurgitation. So we know that it assumes no temporal variability, and we know it's very temporally variable. We know it's not round. It's star-shaped or elliptical or crazy shapes that we've seen. In addition, look at this biplane image of a PISA. You can see that there's a narrow portion and then a wide portion of the jet. We know that in functional disease, which forms 90% of our 80 to 90% of our patients, that they're tethered. And so it's no longer approaching a flat surface. And then look how laminar that flow is. So the aliasing velocity is not significantly less than the peak velocity on the low pressure tricuspid regurgitation side. So none of the PISA quantitation assumptions of that methodology hold. And therefore, we know that we are underestimating the severity of disease by PISA. It's easy to do, and that's its the biggest advantage, but really the disadvantages are just tremendous. And so even though we are going to use PISA because we have outcomes associated with it, this is the TVARC document. It's an academic research document. It's not a guideline, but it suggests that there are indeed multiple different ways of quantifying, including PISA, of course, but 3D vena contracta area and then quantitative Doppler. And the new method is quantitative Doppler, and there's a couple different ways of doing that, but we do believe that that's one of the main ways that we will in the future be quantifying severity of regurgitation. So in the TriLine SCOUT study, we found that we could reduce tricuspid regurgitation orifice area by about 20 to 40 millimeters squared by reducing the annulus by about 25%. And the problem is that we were starting with torrential, so that we went from torrential to severe. It's 2 grades down, but because it went from basically severe to severe, we got a lot of pushback about whether or not we were doing anything. And of course, we strongly believe that we were doing a lot since the patients all felt better. And so we developed this scale because of our experience there and prior to the initiation of the Triluminate trial. So this was generated so that we could determine 1, 2, and 3 grade reductions, as well as put labels to the severity of disease. And so the patients that we ended up seeing coming in the early trials were all massive and torrential. We even had a patient with a regurgitant orifice area by 3D of 4 centimeters squared. So these are patients that are very, very sick that were coming to us. And we have lots of data now supporting the fact that there are indeed increased grades above severe that have prognostic significance. As a matter of fact, when you look at the spline curve on the far right there, you can see that there is indeed a continuous hazard when you use PISA EROA with mortality. And so the higher up you go, the worse the prognosis, as we've seen with every other natural history study with tricuspid regurgitation. But remember that post-tricuspid valve intervention, we also know that massive and torrential predict outcomes. So multiple studies show that it's much harder to get to moderate or less when you have massive and torrential to begin with. And indeed, baseline massive and torrential in and of itself determine outcomes. And so the European guidelines have adopted the new grading, extended grading scheme, particularly in those patients who are being considered for transcatheter tricuspid valve interventions. Now, the new classifications of tricuspid regurgitation have been pretty well outlined in a number of different documents. This is TVARC, but it's in the European guidelines as well, where we've now taken pacemakers out of the primary disease. Again, not only because it can't be primary, there's a pacemaker in there, but also because we know that it independently determines outcomes. And so primary CID, and then 2 different types of secondary disease, ventricular and atrial. So these are examples of primary disease by transthoracic echocardiography. Remember the 3, because the tricuspid valve is a near field structure, we get fantastic 3-dimensional imaging views. And I highly recommend that everyone adopt 3-dimensional imaging, both without and with color, to look at the morphology of the valve. Some of these will be candidates for intervention, some not. We know that primary disease in general has a better outcome than any type of secondary disease. And among the primary etiologies, degenerative or prolapse has a higher survival compared to endocarditis. Now, these are examples of 2D and 3D imaging for cardiac implantable electronic device interference. Remember again that it doesn't necessarily have to interfere, but what we found is that it can interfere not only with the leaflets, but with the subvalvular apparatus. We've actually seen pacemakers, and sometimes CT can help us with this, embedded on top of the papillary muscles, preventing papillary muscle adequate function and fibrosis of the papillary muscles. And so pacemakers can cause a TR in a number of different ways, including thrombi that can form on the pacing wires and cause pulmonary hypertension from thromboembolic disease. Now, the relative reported frequency of pacemaker-related TR varies in the literature. I mean, it's just tremendous, from 7% to 45%, and part of it is just the way that your you're diagnosing incidence of CIED related TR. So is it an increase in grade of TR, or can you actually see it? And much of it is related to the fact that these are old studies and didn't use three-dimensional imaging to make the diagnosis. And so we don't really know what the prevalence is of TR related disease. We know that in the Triluminate trial early on, when we were excluding almost all pacemakers from the trial, we had there's about a 35% prevalence of pacemakers that kind of come into the trials, but only 16% early on ended up in the early trials, so the early feasibility trials, ended up getting TEER devices. So we think about half of the patients that we think that have pacemakers in there probably actually have the lead causing the TR. The others may just be incidental. But even so, this study coming out of the National Echocardiography Database, again, of Australia, NEDA, showed that pacemakers, no matter what, are associated with a nearly twofold increase in probability of progression to moderate or greater TR. And that may be from the primary disease process that required the pacemaker or from the pacemaker itself. And that there is indeed a significant mortality associated with moderate or greater TR. So that any pacemaker with moderate or greater TR obviously deserves a lot of frequent follow-up because that progression may occur very rapidly. Now, as far as atrial secondary and ventricular secondary disease, Jan Topilsky early on described two different types of ventricular, of secondary tricuspid regurgitation. One, which he called idiopathic, and this is atrial secondary, where you have a dilated annulus and right atrium. And in that setting, not enough leaflet to cover the dilated annulus. And then you had what he called pulmonary hypertension functional TR, which is now ventricular secondary TR, where you have dilatation of the RV, whether it's primary from a cardiomyopathy or secondary to pulmonary hypertension, whether it's pre or post capillary. And that ends up causing pulling away the anterior papillary muscle, tethering of the leaflets in the absence of as much annular or right atrial dilatation. And that was shown again by three-dimensional imaging. This is Denise Moraro's seminal work looking again at the ventricular volumes by 3D, tenting volumes of the leaflets, annular areas and volumes, but mainly areas, and then the right atrial volumes. And she showed that all patients with secondary disease will have dilated annuli and right atria, but in the ventricular secondary, you have also right ventricular sphericity, loss of that conical shape, dilatation of the mid-ventricle, and tethering of the leaflets, whereas that is absent in the atrial secondary disease. So that's really how we can define those disease processes. There are those morphologic differences, as you can see here, the marked tethering in pulmonary hypertension and the lack of tethering in atrial secondary disease. But this is one of the classic patients that we end up seeing, and it's always curious as to why they have this kind of morphology of a normal LV, a little bit dilated right atrium, no significant tricuspid regurgitation, but massive dilatation of the right atrium and annulus. And in that setting, voluminous tricuspid regurgitation, which then results in dilatation of the right ventricle. And these are patients with classic atrial fibrillation, but probably also heart failure with preserved ejection fraction. And when we look at those particular patients and how they remodel their atria, it turns out that the patients with normal LV function, so think of HFpEF, are the ones that end up with dilating the tricuspid annulus out of proportion to the mitral annulus. And those patients with LV dysfunction as well as atrial fibrillation will have an equal dilatation of mitral and tricuspid annulus, and hence may have both tricuspid and mitral regurgitation. When you look at the different outcomes related to atrial secondary versus ventricular secondary, there are a number of different studies now that have attempted to define the difference between those two etiologies. And so using the ACC-AHA guidelines, which were the original Topilsky definitions of atrial secondary or functional disease, idiopathic functional disease, that included all patients with atrial fibrillation, normal ejection fraction, and relatively normal pulmonary artery pressures with no residual left-sided valve disease and normal appearing tricuspid leaflets. And when Gavazzoni looked at the outcomes of ventricular secondary was associated with a twofold increase in 1 year combined endpoints compared to atrial secondary disease. And then look at the actual outcomes, and you can see that atrial secondary outcomes at 1 year is looking very, very familiar, similar to the triluminate outcomes. When you look at the multivariable predictors of outcomes in atrial secondary disease, it is tricuspid regurgitation. And that's what we actually targeted for the triluminate trial. We didn't want to have outcomes determined by other things. We wanted it determined by TR severity. With ventricular secondary disease, it's not only about the TR severity, it's also about RV function. And obviously, in retrospect, perhaps we should have widened our criteria to allow more of the ventricular secondary disease patients in to be able to see a mortality outcome. While secondary TR then is the only parameter independently associated with prognosis in atrial secondary disease, please look at the RV function, which we'll talk about also in a second, when you're looking at outcomes for ventricular secondary disease. This study used a cluster approach to define the morphologic cutoffs for atrial secondary disease. And so this is one of the studies, there's another one as well, that allowed us to perhaps put our money down on the actual cutoffs that we should use to define atrial versus ventricular secondary disease. So tenting height of less than 10, mid-ventricular mid-ventricular RV dimension of less than 38, and a ventricular LVEF of greater than or equal to 50. And you can see that with either conservative therapy or with transcatheter therapy, that atrial versus ventricular.
Deli and all that.
Sorry, there's someone not muted, perhaps. But the atrial versus ventricular disease had better outcomes. Now, this is the one of the most recent studies looking at the prognosis of the different types of functional disease, and they divided it into the main causes of ventricular secondary and atrial secondary disease, and you can clearly see again that there's a difference in outcomes, which has been replicated now by these multiple studies. But in addition, as was shown early on by Jan Topilsky looking at the Mayo Clinic database, pulmonary hypertension is the worst outcome. And so this was confirmed again by this recent study. So this is the cutoffs that are used both by TVARC and by the PCR tricuspid focus group. We collated our cutoffs to make sure that they were the same for both documents. And you can see here that, again, these cutoffs are based on data as best data that we have, and therefore it can help define whether or not you have an atrial or ventricular phenotype. The risks for atrial secondary disease, again, based on data, are listed here, but one of the main ones is heart failure with preserved ejection fraction. And so we've looked at patients with heart failure and preserved ejection fraction in other studies, and clearly showed that those patients with HFpEF versus HFrEF, the tricuspid regurgitation will indeed predict outcomes. And we do believe that PEF with TR is a phenotype, perhaps, of heart failure with preserved ejection fraction, or perhaps its own phenotype. Clearly, we see more and more tricuspid regurgitation as HFpEF gets later in its disease process. And we are about to publish this new tricuspid regurgitation in patients with heart failure and preserved ejection fraction review that was accepted in JACC. And so look for that. It discusses all the findings we have to date related to the prevalence of tricuspid regurgitation in patients with HFpEF and the outcomes therefrom. Now, the one thing that we've discovered also is that, in all honesty, when we get a patient that's very symptomatic and coming in for management, they're late in their disease process, and therefore there are a lot of overlapping features which may be the majority of the patients that we end up seeing have these overlapping features between atrial and ventricular secondary disease, given the chronicity of the regurgitation. But the one thing that may help differentiate is the RV systolic function. So we don't really have we haven't yet decided what RV function parameter may help us the most in TTV eyes. But we do know that it's a complex contraction mechanism. We think that there's three typically separate mechanisms. One is the bellows effect, so that stabilization of the septum and then pushing in from the lateral side with the circumferential fibers. There's the traction on the free wall, so we've already talked about interventricular dependence, but it's not just the septum, it's also that the RV is connected, it's just kind of lopped onto the side of the LV. And so anytime the LV is moving and contracting, remember it wrings itself, the LV wrings itself out like a towel. It helps with that peristaltic motion of the RV. And then of course the contraction of the longitudinal fibers, which are the inner layer of the two fibered RV, is a very prominent contraction force for cardiac output. And the RV is extraordinarily efficient. It uses only 25% of the stroke work of the LV, and part of it is the combination of all of those different mechanisms of contraction. Now, we have all these methods for assessing RV function, obviously, and size. Many of them relied primarily on longitudinal shortening, which is perhaps the majority of contraction with a normal patient, but it is not the majority, probably in patients that have tricuspid regurgitation or otherwise abnormal function. And so we do have to figure out other methods of assessing more global RV function. One of those is fractional area change, of course. And then the other is going to be a three-dimensional right ventricular ejection fraction, which we think takes into account all the different mechanisms of RV function. In the TVARC document, we've attempted to lay down, which no other guideline has done. This is not a guideline, but a consensus. But no guideline has separated out mild, moderate, and severe dysfunction. But using what we have of normative data on echocardiography, we've then attempted to determine what is mild, moderate, and severe dysfunction. And there are studies already in the works looking at whether or not these definitions will predict outcomes. But what we also didn't include in that chart is something called RVPA coupling. And RVPA coupling may be the best way to describe RV function because the RV is very, very sensitive to afterload. So remember that the RV has to eject the entire stroke volume out out the right side, but against a closed mitral valve. And so now, of course, it's extraordinarily sensitive to left atrial pressure, to pulmonary artery pressures, both pre and post capillary. And so it is a highly sensitive ventricle, and it's only got 2 layers of myocardium. So RVPA coupling, we believe, is going to be one of the best ways of assessing RV function, no matter what the disease process is. And this is just a smattering of the literature on the use of RVPA coupling to determine outcomes in a variety of different cardiovascular disease processes. But indeed, it has been looked at for tricuspid regurgitation. And one of those studies was by Philip Lurtz, and the other one by out of the TriValve registry by Mickey Brenner, one of our fellows. And they looked at TAPSE over PASP by echocardiography and or invasive measures. And so by echocardiography, which is the Brenner paper, the cutoff is 0.41, and by invasive, it's 0.29. And in this study, which looked again and did invasive measures of PA pressure, they again agreed with both of those cutoffs. They are different because the PA pressure estimates are different, right? So we're a little more accurate, as we should be, with invasive measures of RV of PASP, and therefore as you can see, the prediction of outcomes is a little bit stronger, not a lot stronger, but a little bit stronger with RVPA coupling using invasive PASP. But what Denise Muraro has done is decided to just take out PASP from the RVPA coupling metric by echo. And in doing so, you can use three-dimensional echo to calculate the RV forward stroke volume and then the end systolic volume. And so in doing that, the systolic volume divided by the end systolic volume was a better predictor than any of the other non-invasive measures of RV-PA coupling. And so we do think that we have methods that don't rely on the estimate of PA pressure. And the reason why PA pressure estimates are bad is that we can't directly measure right atrial pressure. As we get more and more tricuspid regurgitation, we know that we have a cutoff sign, a V-wave cutoff sign, and that's because of rapid equilibration of the RV and RA pressures. So RA pressures are extraordinarily high, but we're not able to measure those. We have been stuck with just using three different cutoffs, three down here in the bottom, 3, 8, and 15. But in this study, looking again at invasive RV-PA coupling, you can see that the actual invasive right atrial pressure, whether or not we thought it was 3, so a small IVC with collapse, versus 15, which is a large IVC with no collapse, the spread of true right atrial pressures is the same. So we're just terrible on echo at estimating right atrial pressures, and we probably shouldn't bother doing it right now using the IVC. We are investigating other measures such as liver elasticity in order to try and determine right atrial pressures non-invasively, and we'll have that to you hopefully in the next year or maybe 6 months. When you look at the one other thing to understand about tricuspid regurgitation, again, is that interventricular dependence. And this is a beautiful study, the Heracles heart failure with preserved ejection fraction trial that looked at prospectively, non-randomized, of course, invasive measures of the right heart, as well as CMR of the shape and size of the relative size of the ventricles in order to determine what was going on after patients got the TEER device. And what you can see, and what you all have seen, is that with very late stage patients and massive right ventricular dilatation, you're going to have flattening of the septum in diastole, which then obviously impacts diastolic function and diastolic filling of the LV. And that's why some of our patients, I believe, present with dyspnea and why their BNPs are high, even though they don't have left heart failure. Their left heart looks like their ejection fraction is normal. But they have abnormal diastolic function. And then when you reduce the amount of tricuspid regurgitation, you circularize the LV, you now improve the diastolic filling and the forward cardiac output. And that's what we hope to do with our TEER devices. And the resumption of the septal curvature is a good thing, but in the setting of Laplace's law, we know that that resumption of the circular shape is going to increase wall stress, and that is why, and this is going to come out in that review article that I just told you about with heart failure with preserved ejection fraction. We had proof from the Triluminate trial, and this is from the FDA panel, that indeed the BNP went up. Now it actually increased after, particularly the NT-proBNP increased after the device went in. And part of that, we believe, was also proven to be related to the interventricular dependence and the change in the size of the LV in comparison to the RV once you've put the device in and reduced the amount of tricuspid regurgitation. So again, something to think about and perhaps not worry about as much when you see that BNP go up after your valve replacement or repair. Now, sorry, this is a repeat from prior. Okay, so now what about the guidelines? Well, the guidelines in the next few minutes obviously have a number of different recommendations. The European guidelines chose not to give a class of recommendation, and we have no class 1 recommendation for medical therapy because there's no data. But we do know that diuretics work to reduce congestion. They're volume overloaded. But late in the disease process, we start to see that the diuretics diuretics don't work anymore, and we get bloating and abdominal, increase in abdominal size with ascites and poor cardiac output. And this fluid retention obviously is the main thing that drives these patients sometimes to coming to us. But this is already late in the disease process, and may have already initiated the downward trend in atrial and ventricular arrhythmias that we end up seeing in our patients. And so the cardiorenal cardiohepatic syndrome are extraordinarily common in our patients that are presenting now for the trials. We know that if we were aggressive about diuretics, we could treat that congestion. And this is one of the review articles where we suggest how to manage your diuretics, including escalation of the diuretics. But in fact, is escalation a signal for us? So we know that when we start to have the need for a second diuretic or to add that mineralocorticoid receptor antagonist, perhaps that's the time to intervene. But really what we're doing is intervening at the time when they become diuretic unresponsive. And this is probably a super bad idea. We know that with the treatment of heart failure with reduced ejection fraction, we can also affect outcomes. And so this is the Euro SMR study that looked at the TEER device, showing that if you improved your tricuspid regurgitation, which occurred in a large number of patients, that you had better outcomes. There's also studies looking at resynchronization therapy, showing that 22% of patients with resynchronization therapy will reduce their tricuspid regurgitation and indeed have better outcomes. We know that if you convert atrial fibrillation to sinus rhythm, whether with active restoration or just spontaneous conversion, that they will remodel their chambers and therefore reduce both right and left AV valve regurgitation. And then finally, we know that even though we don't have data, that pulmonary hypertension experts, this was a panel of experts, use tricuspid regurgitation increase in severity to tell them to increase their medications for pulmonary artery hypertension. So we do believe that all those things are important for our management of our patients, in addition to obviously the management of pacemaker leads and pacer-related tricuspid regurgitation. This is a article hopefully that will also be coming out soon. Currently in proof stage. So the goals of directed therapy are to reduce congestion, treat the left-sided disease, treat the pulmonary hypertension, and manage the rhythm. But what about intervention? So intervention, we believe, has high mortality, in-hospital mortality associated with it. These are considered old studies. The Dreyfus study is from 2020. But anyway, considered old because they looked at an older population that received the tricuspid valve intervention. And clearly, the New York Heart Association class 3 and 4 and moderate or severe RV dysfunction predicted outcomes, meaning that we're getting to these patients too late. On a more contemporary look at the databases from 2011 to 2020, the operative mortality was felt to be 7.3%, and that's taking out those patients that had endocarditis, since those patients tend to be very young or much younger and have a much lower operative mortality. And so still not a trivial operative mortality. And but a lot of people have quoted this article coming out of Texas, showing that the outcomes are better than what have been reported before. The problem with that is that these aren't the patients that we're seeing. So these are patients with only 46% functional, 14% with endocarditis, and this is really not the population of patients presenting for intervention. When you look at the patients with the functional etiology that got replacement, and you look at their baseline characteristics, those are the patients that are typically the ones that we see for intervention. And here they had to replace in 33%, they couldn't repair, they had to replace in 33% of the patients. And in addition, those patients had a pacemaker rate of 36% versus 12.4% for repair. So there's a lot of comorbidities also associated with operating on these patients. The tricuspid valve replacement patients, thus, in this study, are really the ones that most closely replicate the patients that we see coming for TTVI, and those had an in-hospital mortality of 7.1%. Now, this is another study showing the same thing. These are not the patients that we end up seeing coming for TTVI. Endocarditis in 27% of the patients, functional disease in only 45% of the patients. And so they showed again that 30-day mortality was pretty low at 5.4%, but again, not the patient population that we end up treating. Now, this is a study coming out of China that does look at a patient population that have come to TTVI, and this is a patient population that already had left heart surgery. So although this population still tended to be much younger, 50s, in their 50s, ours are in their 80s, it did otherwise match with New York Heart Association class 3 and 4. And so when you look at this study, the in-hospital mortality was 11%. So again, we believe that the in-hospital mortality is still quite high in the patients that come to us for intervention. But the practice variability is extraordinarily high because we're operating too little. Now, why do we operate too little? Maybe because we haven't seen a lot of great outcomes associated with surgery. This is the study that adjusted for immortal time bias and showed that indeed there was no benefit to surgery versus medical therapy in those late stage. This is again an early study, late stage patients that come to us. And so other studies have confirmed this, that once you've kind of gone over the edge, it's pretty hard to show that intervention, whether surgical or transcatheter, is going to benefit. So this indeed are the patient population that we see. They're old, they're in their 70s and 80s, they've got AFib, 90% of them have AFib. They all have hypertension, so maybe heart failure with preserved ejection fraction, kidney disease. They've all got low eGFRs, maybe up to 30% in the replacement trials have prior pacemakers. They've all had 30% of them have prior left heart surgery, and then they've got all these abnormalities of their lab tests as well. So why do we intervene too little, too late? We've covered the fact that we recognize signs and symptoms too late, or right heart failure. We fail to accurately quantify TR and RV function, and we have a poor understanding of when to intervene. Now, toward that end, there are a number of different natural history risk scores which need to be validated. So this is the Laura Breidinger study from Mayo. This is Tim Wang, and this is the Hochstadt score. And so all of them need to be validated. But there are also surgical risk scores, so risk scores for taking the patients to surgery, including the Euro score, which performed the best in this study by Tim Wang again. And the MELD score had an intermediate performance, and the STS-TVR score performed the worst, although it wasn't bad. It's just had a C-stat of 0.6. All scores were associated with mortality and follow-up and discriminated most post-operative complications. So we do think we have scores, and now we have the TRI-score. So the TRI-score has been now validated, and I don't have time to cover all the studies that have now used the TRI-score to predict outcomes. But remember that two of the components is right heart related. So it is the right heart indeed, and getting to the right heart early enough that we believe it needs to be done for us to affect a true mortality benefit. Now, we have two devices that are now FDA approved, the TriClip and the Evoke device. It behooves us to understand who's appropriate for each of the devices. This is a new review article that attempts to give us an algorithm of sorts in determining who to take to each of the different devices. And then the PCR working group has come up with the favorable, feasible, and unfavorable anatomy, not only for leaflet approximation devices, but also for annuloplasties and orthotopic valve replacements. But the important thing to remember that it is the reduction in TR that is important to us here. We have already shown from multiple studies that at least a 1-grade reduction will affect outcomes. And in fact, it's probably a 2-grade reduction in this study that is the best outcome. So if you have a greater than or equal to 2-grade reduction, or at least a 1-grade reduction without pulmonary hypertension, then you can indeed affect outcomes. But procedural success determines outcomes. And toward that end, a number of different studies have now looked at what will predict procedural success for T-TEER. And it's a lot of different parameters. So there's a lot for us to think about. Now, as far as the annuloplasty devices, we don't really have anything currently. We have early feasibility coming for the 3rd iteration of the Cardioband device coming soon. So I'm not going to talk about this a lot, except to say that the ventricular functional disease or secondary diseases should probably not be the target for this device. Now, for the replacement devices, they have the field continuous number of unfavorable anatomy, but remember, we only have certain sizes. In addition, we really don't know what to do with RV function. So as you reduce the amount of tricuspid regurgitation, what looks like normal or at least borderline normal RV function becomes really severely reduced RV function. And yet these patients still are able to improve their cardiac output. There's a lot of different challenges that we have with this disease, so it's not also a slam dunk, but we do believe that all devices may reduce the amount of tricuspid regurgitation, and in that setting should affect outcomes. This is a propensity matched tri-valve registry study showing, again, that we believe the outcomes with mortality should be improved. Other studies have shown that we're only going to get functional quality of life, but again, this beautiful meta-analysis suggests that 1-year mortality should be less than what we've projected it to be in the past. I'm going to skip through some of this to say that the Evoke device was approved in February for the improvement of health status, but it was approved because of, although the safety profile was not perhaps perfect, it did have tremendous efficacy. So you will take the TR to mild or less in 90% of your patients, more than 90%. And so with that, in the FDA panel pack, they were able to look at partial cohort. This is not the full cohort, showing that all signals for mortality, function, and heart failure hospitalizations were in the right direction with advantages to treatment with the Evoke device. Now, the TEER device was not able to show that outcome, but it was also approved based on a very, very good safety profile and obviously some efficacy. So about 80%, only about 56% will get to mild, but 86% will get to moderate or less. Now, this is the difference between the trials. So TRISCEND group is older, more New York Heart Association class, a greater number of females, had a lower ejection fraction, more renal dysfunction, more permanent pacemakers, a lower KCCQ score to start with, and greater numbers of heart failure hospitalization in the prior year. So this is extraordinarily different patient population, which is probably why we were able to see a mortality change, not dramatic, but I mean a difference between the treatment group and the optimal medical therapy group. So we're kind of at the top of the hour, and I haven't allowed a lot of questions, but the bottom line is it all about TR reduction? And indeed it might be, but remember that when we're looking at the different devices, they have their strengths and weaknesses. None of the devices are perfect. One is going to be real safe, but may not get you down to mild. The other will get you down to mild, but has a lot of other things to think about, like thrombosis, pacemaker rates, and bleeding. And so what we look at for these devices and how we decide which device is just a work in progress. I mean, we need the multiple tools in the toolbox. Thanks for your attention. I probably could have gone on for another 20 minutes, so sorry about that.
Thank you, Dr. Hahn, for that wonderful, comprehensive talk that provides us so much insight, new insight into the tricuspid valve function and dysfunction. If you can hold on for a few minutes, if we may have some questions still. Are there any questions in the audience? Yes, Victor, Dr. Mollis.
Hi, Dr. Hahn. Thank you so much for this wonderful and very talk. My question was, it referred on how you use hemodynamics to make your treatment decisions. You showed a lot of data about how precapillary pulmonary hypertension in different forms of post-capillary pulmonary hypertension affect the RV function. Do you do a heart catheterization, right heart catheterization on all these patients? Do you have cutoffs that you would say this is not somebody that should get an intervention despite the fact that they have significant TR?
Yeah, that's such a great question. So we're still gathering the data, but the trials right now excluded patients with severe pulmonary hypertension. So that was determined differently. You know, the criteria were a little different in the different trials. Some used 70 millimeters of mercury, some used 60, some used a PVR of 5 Woods units, some used invasive versus some said that the echo had to be confirmed by invasive, et cetera. Our current practice here is that we like we like to do right heart cath, because I mean, it's just for a couple reasons. One, we don't think obviously that we're very accurate, as has been shown before, with estimating the true pulmonary artery pressures by echo. And we're learning a lot because we're using those patients that were right heart cathing and doing that liver elastography in order to try and determine if we can more precisely quantify right atrial pressures. But we do like to do the right heart cath. And at this particular time, you know, because we now have commercial devices, we haven't really tested the waters as to whether or not we will do a severe pulmonary hypertension patient. We still been really using those cutoffs by the trials to make sure that we get the same or better results that the trials have gotten. And so I do think those are a patient population that will require further study as to whether or not there's still an improvement in outcomes with the TTVIs. But I don't think we know, and we've not tested that.
We have another question from the audience.
Thanks so much, Dr. Hahn. My name is George Hahn. I'm the structural heart fellow here. Really tremendous talk. I just wanted to ask a two-part question. I know the RV and the LV remodel, like you mentioned, after treatment of TR, how quickly did they remodel? And then with tricuspid valve replacement, do you anticipate that with remodeling and changing of the morphology, we might run into paravalvular leak or potentially, you know, later complications of valve replacement?
Yeah. So, I mean, so the first part is RV remodeling. So we know that on follow-up at 30 days that we already see the remodeling. What we found is that there are a certain number of patients that have acute afterload mismatch, and those patients have really, really bad-looking RVs, and you support them for about 5 days, maybe on with inotropes, and they get better and can be discharged within about 7 days. So we do know that there'll be a direct hit on some of these ventricles, not all of them, and there may be something. It may have something to do with the beginning right atrial pressure, and so some of our patients with massive right atria, even with pulmonary hypertension, actually have normal right atrial pressures, and those patients will probably do pretty well. But the ones that don't have normal right atrial pressures, we believe we've modeled this using a PV loop computational model. And it's those with perhaps poor right atrial compliance or high right atrial pressures that we may end up seeing more acute afterload mismatch, and then you have to support them. If you don't have that, then what we've seen is even at the 30-day echo, we begin to see recovery of the function. And the easiest thing for us to do is still going to be RV strain. That's super fast. Although RVEF is pretty good, but by transthoracic, we have a little difficulty with, you know, a temporal and spatial resolution. So our RV free wall strain, super easy, all based AI based. And what we see is the drop in RV function immediately after the valve goes in starts to recover, and that'll continue to recover. So I just did a 1 year yesterday on an Evoque, and got better again, you know, from the 30-day and 6 months. So I think it'll continue to recover and may continue to remodel as far as RV size as well. And RV size remodeling is also associated with improved outcomes in the surgical literature. So we do believe that all of that together is going to continue to be really, really good. We do not see an increase, or have not seen an increase in paravalvular leak with the remodeling. Remember, these are relatively, the Evoque is relatively large in the annulus, and if it's sized for the biggest part, the biggest annulus that you've got. So even if you remodel, it's going to just shrink itself. You know, it can't shrink itself smaller than the valve. And so we haven't seen paravalvular, but obviously you have to worry about structural valve deterioration or thrombosis. That's not a trivial risk in the patients that have atrial fibrillation or reduced RV function, right? So you have very low stroke volume. And so it's been a problem, and we've had to, in patients who come in and they're on a DOAC for their atrial fibrillation or whatever, if they develop thrombus, we'll have to switch them to Coumadin. And so we prefer all of our patients after Evoque be anticoagulated in some way.
Well, Becky, thank you very much for a wonderful talk. We look forward to seeing more of the work being published as it's coming out in the near future. And thank you again.
Okay, thanks for having me. Sorry I ran over.
I'm sorry, we didn't want to stop. We could go on for a long time. Thank you.
All right.